This seminar is about research. In particular, it's about public health research and trying to construct, by peering into the future, some kind of an agenda, some kind of sense of direction for public health research going forward. It's a complicated business, public health research, primarily for three reasons. First of all, that the issues are very large scale. Second, they're intrinsically intersectoral. They concern not only health, but policy, environmental issues, social sciences, hosts of other interests and professionals. And third, the research directions, therefore, have to ultimately merge and one hopes to a significant degree integrate. I'll be very brief. I just want to make 3 points about constructing a public health research agenda. The first is that the disease pattern that we're confronting is intrinsically unstable. It is constantly evolving, and the reason it's intrinsically unstable and constantly evolving is that the underlying determinants and causes are themselves unstable and constantly evolving, not only for biological, but importantly for social and increasingly for political reasons. So the problems are unstable and very large. Second, as I indicated, they are intersectoral, and research agendas have to appreciate that and incorporate that. And third, these issues are a very broad social, political, and political interest. They're not confined to health by any means. Increasingly, environmental issues are involved, and overlying the disease pattern to be addressed are a number of really enormous disease pattern drivers. One that's on us at the moment is climate change. Another is political shifts. A third is the increasing despoiling of major ecosystems by human activity. So this is complicated. It's a lot more involved in some ways than biomolecular research is, because it involves players from so many other sectors. So we're very lucky today to have with us two people who have been thinking and worrying about these issues for a long time. Dr. Jim Kern is Dean and Professor of Epidemiology at the Rollins School of Public Health at Emory University. Before he came to Emory several years ago, he had a long and distinguished career at the CDC, where he very early in the HIV outbreak got involved, remained with that, became a prolific researcher and publisher in HIV/AIDS issues, and ultimately directed those efforts at the CDC. He has many honors. He's a member of the National Academy of Medicine, the American Academy of Arts and Sciences, and we're very privileged and happy to have him with us today. Our faculty commentator is Dr. Linda Fried, who is a Dean and Delamar Professor at the Mailman School of Public Health here at Cornell. Dr. Fried is a leading thinker on issues in aging and its medical, public health, and broader social context. Before she came to the Mailman School, she had a distinguished career at Johns Hopkins, where she led the effort in geriatrics and gerontology, held professorships in public health medicine and nursing. So she was 3 professors simultaneously. And she has also a number of many honors, including membership in the National Academy of Medicine. She was co-chair of a National Academy of working group on a major agenda going forward for aging, and in fact was the inventor of what amounts to a social therapeutic effort in aging, the Experience Corps, which recruited retired and elderly people back into important social roles. So we're in privileged company with our two speakers, and we'll start with Dr. Kern.
So thank you, Dr. Barondess. It's a real privilege to be here at Columbia, or at least almost at Columbia, virtually. You have an outstanding school, and I'm really honored to be on the agenda with you, Jerry, and Dr. Freed. What I'm going to do today is going to be a little bit more about politics and history than it is about research per se. But I've learned over time that HIV is both an infectious disease as well as a chronic disease. So many of the issues that relate to HIV also do relate to chronic disease epidemiology and prevention. First, I'd like to contrast the response to the AIDS epidemic in the United States with the response to COVID. I'm asked to do this often because I was put in charge of a CDC task force when the first 5 cases were reported on June 5th, 1981. There are, of course, many differences, and I want to highlight both the differences and the similarities. First of all, it's important to recognize that public health is inherently political. It's always political, whether it's climate change, cardiovascular disease, reproductive health, HIV, or COVID. It should not be partisan during an epidemic, and that's one of the most alarming things when it turns highly partisan. In the beginning with AIDS, 1981, cases were reported of chronic disease that were extremely unusual. Opportunistic infections, unusual cancers, autoimmune disorders that were occurring in previously healthy gay men. The first thing we did at CDC was assessment, and we set up a case definition so we could find out whether or not these things were really new and to whom they were occurring, to help us find out what the cause might be. We were certain not to have a case definition deal with risk groups per se, but rather to help us define risk groups. And we aimed a case definition at specificity. We wanted to make sure that the cases which were so unusual when doctors would see them were actually the ones that define the trajectory of the epidemic. First thing that happened then, of course, was that we were able to devise with active surveillance that these cases were new. They had not really occurred in the United States before the very late 1970s, and they were increasing rapidly at the first doubling every 6 months. It seemed like everybody who was diagnosed with one of these infections or cancers would ultimately die. So it looked like there would be 100% case fatality rate. Cases were primarily in gay men, but then also found in heterosexual injecting drug users, again, primarily in the East Coast, New York area, and New Jersey area, but also in Puerto Rico in the early stages of the epidemic. This then involved men and women, and sometimes even the children of injecting drug users or their partners. Finally, cases were diagnosed in people who had been hemophiliacs, people who were receiving very large doses of blood products, which were essentially untreated and were known to transmit hepatitis B, as well as what was then non-A, non-B hepatitis, and were essentially the canary in the coal mine for blood transmission of whatever it was that caused AIDS. This allowed the CDC to issue prevention recommendations for healthcare workers and laboratory workers, as well as the public, about how to avoid AIDS, even though the cause was not yet known. And because it looks so much like a new virus, we could define groups that should not be blood donors, because we knew there were going to be cases occurring in people who received blood products. So the recommendations for prevention came out before the etiology was discovered. Then in 1983, the French at the Institut Pasteur discovered a virus which they called LAV. Later on, and about a year later, Dr. Gallo at the National Cancer Institute and his group discovered a virus they called HTLV3. There were some scientific disputes about this, but the antibody test for this virus was licensed in March of 1985. So here we are 4 years later before a blood test was available for what caused AIDS, in contrast to what happened with COVID, in which we were talking about a number of weeks. The sequencing of these two viruses showed that Gallo's discovery was actually LAV itself, which had been shared with his laboratory and then re-isolated. And so there was a big patent dispute, and eventually the French won the Nobel Prize and got all the royalties. What we learned after 1985 is that a positive antibody test was equivalent essentially to a lifelong infection with the virus itself. So that once people were infected with HIV, they were infected for life with a mortality rate which very much looked like 100% over time. Another important factor was that people infected with HIV would not really get sick for 5 to 10 years after they were infected. So the cases we'd been studying of AIDS that were close to death were people who were infected likely 10 years earlier. That was true in a community as well as in an individual. And so looking backward, we would estimate that when those 5 cases in gay men were reported, there were probably already 250,000 cases in gay men infected. And by the time the antibody test was licensed in March of 1985, as many as 500,000 gay men in the US were already infected. Now you can multiply that by millions, of course, worldwide, but it goes to say that the infection was extremely well seeded before specific antibody positive kind of prevention recommendations could be made. Now, Ronald Reagan took office in early 1981. He had come to office for 3 reasons in beating Jimmy Carter. One was the embassy in Iran was attacked, and the US embassy took hostages, and Carter was unable to free them. I think maybe more importantly, inflation was very high and unemployment was very high in the United States. So the economy was not doing well. Ronald Reagan took office with 2 promises. One was he would make the domestic government smaller, and he would increase the defense budget and vanquish the Soviet Union. So there was a hiring freeze in government and a diminution of budgets at NIH, the CDC, and elsewhere that confronted us when we faced the epidemic. The administration did not so much interfere with us as neglect us. So I would call that the Reagan administration and AIDS one of neglect rather than interference, in contrast to what we see with COVID. So that we were depleted budget-wise and put on a starvation diet, eventually rescued by a Democratic Congress, but we were not hindered or interfered with in the sense that if the CDC was always publishing the information on surveillance and the expanding epidemic, and we would always have many of us, often me, talking to the press and the public about what was going on. We were never held back from discussing our own scientific or epidemiologic considerations. But President Reagan himself didn't say the word AIDS in public until 1987. Hence the title of the book by Randy Schultz, and the band played on. But it was one mostly of neglect rather than interference. There was not as much direct interference, but there certainly was neglect and no love lost for the populations at risk, who were homosexual men injecting drug users in particular. And eventually there was bipartisan political support for AIDS. There was much more of a bipartisanism then. The Ryan White Care Act, which paid for care and continues to pay for care for people who have AIDS were jointly sponsored by Orrin Hatch from the Republican Party and Senator Edward Kennedy. And then PEPFAR, which is the major international development effort, was sponsored by President George Bush. So we saw much more bipartisanism in the fight against AIDS than we certainly are seeing with COVID. Now, much progress has been made with AIDS, but 40 million people have died and 35 to 40 million people remain infected. About 20 to 25 million are on highly active antiretroviral therapy, which was shown to be effective in 1995. So we went 15 years before we had good therapy, but we still have no vaccine and no cure, and people who are being treated need to be treated for life. And there still is about 1 million deaths a year in the world, with 35 million people currently infected. Now, the COVID epidemic is the public health crisis of the century. Not in any of our lifetimes have we had anything with such great impact. I remember my father telling me that the world changed after World War II. And I think those of us in public health, and particularly the students and young people now in public health, will remember public health before and after COVID. Everything changes in our world and will continue to change in our world. Some good things about COVID include the rapid scientific response. Instead of 2 years to discover the virus and another year to sequence the virus, we had the virus discovered and sequenced within weeks, and the sequence shared with the world. And although inadequate diagnostic tests, we had diagnostic tests available almost immediately. It was discovered, of course, in China, in Wuhan, and there was some initial stalling of information and working with the US in particular, but there was rapid virus isolation, sequencing, and global sharing. And the tests were developed and utilized worldwide. There were rapid successes in Asia, but relatively little recognition or emulation of those by the United States. And so I think part of our own problem has been our unwillingness and inability to seek advice from South Korea, China, Hong Kong, Taiwan, and other places and emulate what they do. And I guess I would throw New York City and New York State into that group for successes. There are initial testing snafus in the US. CDC and FDA played a role in that, but we continue to be under where we need to be with tests, both in terms of quality of tests, rapidity of tests, and quantity of tests. CDC's role in surveillance is quite different than it was with AIDS. I mean, it's ironic that the surveillance for for COVID and COVID deaths and hospitalizations occurs through health departments, and the information is available to CDC, but we rely on the reporting of it to come from Johns Hopkins University, who are largely obtaining the data from state and local health departments and CDC. I would, of course, feel better if the CDC was reporting the cases and there were people from CDC talking about it and interpreting it for the country instead of the various pundits who've been on TV, including me occasionally. But I think the main thing is that where is the CDC in interpreting the epidemic? So the CDC role in surveillance, response, and assessment has been stifled to a great deal and marginalized. Part of our problems with with COVID, is that we've made it overly complex. And we've had our policies made on part of scarcity and wishful thinking. Let me explain what I mean by that. From the very beginning, there were only two things we wanted to do. One was we wanted to save the lives of the people who got COVID. And secondly, we wanted to prevent transmission from people shown to be infected to others. So that means in the beginning, what we'd like to have done was have testing widely available and make sure we've got adequate resources to save people's lives. That begins with testing to find out if they have COVID, It includes ICUs and personal protective equipment, but it also means testing people and their partners and contacts who have COVID to isolate them from each other to prevent transmission. But the scarcity of tests initially led to policies where doctors and hospitals and public health officials were saying, you don't really need to be tested unless you're really sick. Don't come to the hospital, don't come to the doctor if you have symptoms. If you think you might have symptoms, just isolate yourself and you don't need to be tested. Well, that was never true. You always needed to be tested, but we just didn't have enough tests. But it looked like the policy was based upon science when it was really based upon scarcity. So then when we change it and tell people they need to be tested, they say, well, I thought you didn't need to be tested. Similarly, we had a scarcity of masks, and we wanted to make sure that healthcare workers got the first masks. Well, that makes sense, but instead of saying everybody should have masks, but we're going to prioritize healthcare workers until we get enough, we said, well, you don't really need to wear a mask. Well, that isn't true. You always needed to wear a mask, just like they did in China and South Korea and everywhere else. We just don't have enough. The other thing is wishful thinking. Now, cautious optimism or inadequate scientific data is not the same thing as truth. And our first underestimation was, well, we don't think there's asymptomatic transmission. And to back that up, we would say there's one study out of China where it didn't seem like the people in the hospital were more likely to transmit than others. But there were telltale signs of showing that the amount of virus in nasal secretions was just as high in people without symptoms as with symptoms. And an early CDC study in nursing homes in early February showed that asymptomatic transmission was extremely important in nursing homes. But instead of emphasizing that, which would require, of course, a lot more tests and a lot more panic because transmission would be invisible, that was kind of held back with the wishful thinking that asymptomatic transmission wasn't important. A month or so later, some public officials said, well, it looks like there's asymptomatic transmission. I wish we knew about this. I wish we knew that it was like every other virus almost. Asymptomatic transmission is always important, either pre-symptomatic or asymptomatic. Well, the next thing was that children don't get it. We're really fortunate that this doesn't affect children. So unlike every other respiratory virus known to man, for some reason, children are spared. And that was based upon, again, a couple very, very small Chinese studies and the fact that because children were being kept at home from school, they weren't really exposed to each other that much, and there wasn't that much transmission. And while it appeared that they didn't get very serious symptoms and were less likely to die, therefore they were less likely to be diagnosed, again, because of scarcity of tests and the message that children weren't at risk. So then we send them back to school, and we should have known from some of the campfire studies and the camping studies that CDC did that this could spread rapidly in young children and teenagers. But CDC was kind of kept out of the limelight because the concern was we want kids to go back to school. We don't want them to get COVID. And then we find out, of course, that they get COVID and that they transmit it asymptomatically and they can bring it home and give it to their high-risk parents and grandparents. But it was wishful thinking that said children don't get it. So now we're talking about a vaccine. And I'm among those who are optimistic that the natural history of COVID would suggest that a vaccine can be efficacious in studies and shown to be effective, and we can come up with a safe vaccine. But we don't know, because that's why we're doing trials. If we knew that these vaccines were going to be effective 100%, we wouldn't have to do the trials. And we don't know how long they're going to be effective. We're not even sure how long natural immunity occurs. So we think that some of the vaccine trials will show an efficacious vaccine and that it'll at least be partially efficacious. And we hope that it'll be efficacious for longer, for example, than the flu vaccines. So we'd like it to be like a measles vaccine where 95% of people are protected for life. But the HIV vaccines, after 40 years, still don't work. And the flu vaccine is about 50% effective, and it's only good for about a year. So let's say we get a vaccine that's like that, and we can convince the skeptical public that they should take it. Well, if half the people take it and it's half effective, that's going to provide 25% of the public being protected. And it's not going to be a substitute for face masks, social distancing, avoiding small gatherings. But it's kind of wishful thinking that a vaccine will be the magic bullet to take us out of this horrible pandemic, and that it'll be available not only before the election, but even early into next year. Now, you got to remember that if it's shown to be effective next year, I'm currently a member of a vaccine trial. I decided I was going to roll a vaccine trial myself. I wanted to be the oldest person in the trial, but it didn't work. There's some older people than me. But I want to get in the trial myself, and the trial lasts for 2 years. Now, the reason it lasts for 2 years is because they want to know how long the vaccine's effective, and they want to have a better impact on side effects. Well, I get my second dose in October. So by the election, I will have contributed 1 person month to the vaccine trial. And most of these trials are not going to have many people in them for more than 3 or 4 months at most by the end of the year. So intuitively, you're not going to know how long the vaccine is effective by early next year. It could be waning in effectiveness over time. So the reason I'm going to be followed for 2 years is we got to see whether, if I got the vaccine, whether I'm protected for 6 months, 12 months, 24 months. The public doesn't really understand this because we kind of are simplistically told mixed messages about the vaccine. And there's a presumption that that's going to be the end of the COVID issues. So now going to COVID, of course, it's highly transmissible. One of the reasons we underestimated it is that we had COVID viruses, SARS and MERS, which were highly dangerous with high mortality rates, but they had low transmissibility rates. The common cold coronaviruses had very high transmission rates, but very low mortality rates. So they were much less dangerous than influenza. So we assumed that COVID was going to have a transmissibility rate more like SARS and MERS, and the mortality rate more like influenza. But in fact, it's as transmissible as the coronavirus colds, and much more fatal than influenza, although less than SARS and MERS. So how about the politics of this? Well, it's been extremely partisan. It violates my principle of epidemic politics always being political, but shouldn't be always partisan. And it is partisan in a number of ways that are very dangerous. There are greatly increased risk for underrepresented minority populations and for the elderly. There's been stifling of scientists and dismissal of science by the White House and the administration. This has been particularly bad at CDC, but the only person who hasn't been totally stifled is Tony Fauci, and he's the closest close friend, but he's also the closest person to a bulletproof hero that we have in public health and medicine today. He's advised 9 presidents and has such a huge transmissibility. COVID has also underlined the very poor public health infrastructure we have at the state and local levels, and the insufficient resources for surveillance, testing, and treatment. And the lack of national health insurance is made worse by unemployment with COVID. And the gaps between public health and medicine are really shown greatly. There was a period of time about a month ago when we had 1 million healthcare workers laid off, but insufficient people to work in public health on COVID. That wouldn't happen in many other countries, certainly not in Asian countries, where the country would just say, well, you're not doing elective surgery now. Why don't you go work on COVID? Instead, we lay those people off, pay unemployment, and then say, we don't have enough people in public health to do contact tracing or data analysis or anything else because of this lack of relationships. I'd like to, before I turn it over for comments to Linda, I'd like to once again talk about the problems we have in leadership in the country and the implications of that. Even this is much worse than it was under Ronald Reagan, because there's a dismissiveness of science, diminution of work at the CDC, where thousands of people have been working on COVID, and some of the greatest respiratory disease epidemiologists in the world exist and work. Morale is terrible because they're treated and described as seditionists and anti-Fa people and out to get Trump and things which have nothing to do with COVID and simply are untrue. It's very demoralizing, but it's also so short-sighted. A similar demoralization of the deep state at the FDA comes out. And then changing MMWR guidelines, changing prevention guidelines coming from political hacks at the administration level is very, very short-sighted, because we already have a lack of confidence in vaccines in the United States, lack of confidence from underrepresented minorities who are more at risk for COVID and its complications. And now we have people dismissing and minimizing confidence in people who are going to be making those recommendations. So now we're going to have Trump supporters who won't believe the CDC or the FDA, and the minorities who aren't going to believe the CDC and the FDA. And we're going to come out and say, hey, we've got this great vaccine for you. You need to get it to protect yourself and the country. When we just got done telling you a month earlier that the people telling you this are anti-Fa, anti-Trump, deep state people who aren't to be trusted. And so that's very, very short-sighted, and it's damaging to our country. I guess you can tell, Linda, that this upsets me. I'm not inherently a partisan political person, but now they're treading on my career and my turf, and I think the public health of our country. So you may want to disagree with me.
Thanks, Jim. I just realized I had to unmute myself. Well, I think you know that I will not disagree with you, because I similarly am deeply disturbed by what this hyper-partisan environment is doing to our ability to protect the health of Americans and the world, and in all of the dimensions that you have been laying out. And to link some of the challenges that we haven't even gotten to, back to Dr. Barondis's chronic disease theme, of course, as you mentioned, the mortality rates associated with COVID are much higher in people who already have pre-existing chronic illness, chronic disease, who are already highly vulnerable and clearly have much more difficulty resisting the dimensions of COVID, which has led to their high mortality rate. How we protect people from COVID, therefore, also needs, I believe, to include focusing on how we improve the health of Americans in general. And it's, what we've learned over the years, first of all, is that about half of these chronic diseases, at the least, are preventable. That's what public health science has shown us. That some of that prevention, of course, needs to happen within a doctor's office, but much of it needs to happen with how we create the conditions through public health systems to be healthy at a population level. Now, I'm not telling you anything you haven't written the book on, but just mainly to say it out loud for both of us. And it raises another dimension, I think, of the COVID pandemic to me, which is what it's revealing about what we need in a public health system. As to keep people healthy, to use the science we have, which says that so much of health can be invested in, so we create health across the life course. And we do not have to leave it for people to develop diseases which are preventable and then need medical care, because we could help them be healthy. Now, one of the challenges which you alluded to in this COVID pandemic is that it has revealed I think the longer term dimensions of disinvestment by our country in the public health system itself. So obviously the US public health system, which consists of the CDC, as you mentioned, state and local health departments in 50 states and DC, and 3,000 local health departments across the US, and health departments in territories and tribal lands. All of those have prescribed functions and deep expertise, which in a minute I would love for you to comment on, Jim. But if we look at the data, which I have done, it's very clear that the resources for this whole system have diminished over time since 1960, incrementally. The whole system gets less federal resources than it did in 1960. If you look at just if you take the absolute dollars and consider that they're not even inflation adjusted. So we have a workforce across the US public health system, which is now less than half of what it was even 20 years ago, and many retirements pending, and a demonstrated inability in the face of the pandemic, even when health departments were allowed to scale up, and limited ability to do so. So I was wondering, Jim, if you could comment on, from your long perspective, working in the US public health system, about its importance for the 21st century, and what we need to think about to make it more capable of protecting the health of Americans.
So you're absolutely right about the disinvestment in public health over time. And it's happened for a number of reasons. Part of it is due to the inflation of healthcare costs and the fact that state and local governments have to balance their budgets, unlike the federal government. So states are faced with very large increases in Medicaid budgets and other healthcare budgets, as well as a tendency to reduce taxes at their own level. And there's a lot of inequity between states on how much their budgets are by state. So there's not a core amount of money that gets put in public health. And it's a lot easier to cut the public health budget than to try to hold down the Medicaid budget, which is highly inflationary, particularly in times when there's high unemployment and a large number of people on Medicaid. So it's just been easy to watch public health funding get cut over time at the state and local level, and there's no real minister of health. I mean, the CDC is the major public health agency, but they have no really administrative role over or regulatory role over state and local health departments. It's unlike countries where there is a Ministry of Health and the health departments actually work for the Minister of Health, which makes it a lot easier to assure some uniformity. Our federal system is not made well for that kind of work. And part of it's our country, and part of it's our kind of lack of commitment to public health as an infrastructure. I'm optimistic about COVID and the COVID pandemic for a couple of reasons. One is that I think, I can remember, Linda, when you and I were deans a few years ago, when students used to say, my parents say, "What is public health? What are you studying? I don't understand this." I don't think that's going to happen anymore. I think now, there are more epidemiologists on TV than there are economists. And I think people now understand the importance of public health. And we're also seeing some of the limitations, not just at the federal level at CDC, but also in particular at the state and local levels. And maybe there'll be an opportunity to help that out. I know we have some projects here at Emory where we're putting in trainingship fellowships in our district and state health department with some local philanthropy money that's been convinced that there needs to be an influx of talent at the local level and the district levels. So I'm hoping that will continue beyond the COVID epidemic to strengthen public health. It certainly, as we've seen, increase the interest of young people to get engaged in this, both people who have other professional degrees as people just getting public health degrees. So I think we have reason to be optimistic about the future of public health, but it will continue to be a financial struggle, and the organization of our country into 50 states with relatively little national authority will make that somewhat difficult. There's another reason, I think, to be optimistic about COVID, which is slightly separate. And this is, again, comparing it to AIDS. The only good thing about COVID is it only lasts about 3 weeks, as opposed to lifelong. And the implications of that help to explain why communities and states and countries have had success, and why we could have success too if we could have consistent messages and consistent programs. By only lasting 3 weeks, it means that nobody will die in November in the United States who is infected now. So all of the hospitalizations, all of the deaths, all of the infections in people who will in November have yet to occur. So that means if we could magically stop all infections right now, today, September 24th, and we could stop that for 3 weeks, no one would get infected anymore. And that's really why it works in China and Taiwan and South Korea, and even in New York. How could you stop it in New York? The reason you can stop it is it only lasts 3 weeks. So if you can get everybody together and do the hard stuff for 3 weeks or 6 weeks or 8 weeks, you can knock it right out. And I like to use New York as an example. I love New York, but I find people in New York, I find New York to be our most crowded city, where you have the most crowded subways and the most crowds on the streets and the most crowds in your rooms and buildings. And you have the most diversity and lack of uniformity of people, unlike, say, Taiwan. And you have people that have all different nationalities, all different languages, but you could come together and go from 800 deaths a day to 0 in a country with consistent leadership, consistent respect for science, and consistent action. Now, it hasn't been easy. It hasn't been perfect. You didn't solve the nursing home problem. There's other issues that, and continuing this through prevention fatigue is a problem. But New York knocked it out. How could it happen in New York with the worst epidemic in the world? And we can't do it in Georgia. We can't do it in any other place. But it can be done because it only lasts 3 weeks. And there's hope in the future, because after the 3 weeks is over, most people get a healthy immune response, which can be duplicated by a vaccine. So we're going to have some more tools in the future if we can just get our act together now. But, because of partisan politics, we can't do it. We simply can't come to an agreement with consistent activities and consistent messages. So my optimism isn't followed by wishful thinking about where we're going in the next couple of months.
So Jim, one of our colleagues, Wafel Sadr, always talks about the fact that we already have a vaccine. It's a non-pharmacologic vaccine, as you said, of wearing masks, physical distancing, washing our hands, and keeping our environment disinfected. And it works, just as you just said, if people all do it together. Now, there are other countries which have been engaged in this and actually have been able to sustain that social cooperation and are back to work, reporting that they're about 80% back to normal functioning. There are some things they're still going to keep doing. They're keeping wearing masks. They're keeping their physical distancing. They aren't having large meetings together in person. But other than that, life is somewhat back to normal. So this is possible with effective leadership of the type that you're describing. And it is, I think, for all of our audience, very important to see what's possible, and also that we know how to do this until we get a vaccine, and a vaccine will not be the sole solution. This also won't be our last pandemic. Tony Fauci for years has been saying that with the change in our environmental conditions, with a change in the proximity of people living near animals, with a change in terms of global warming, that the frequency of new infections that human beings never encountered before has already been rising quite dramatically over the last number of years, and we expect will continue to rise. So in a lot of ways, it's critical that I think that, and I know you do, that in public health, we learn from this in order to write a prescription for our own field as to how to prepare for the subsequent pandemics, even before we're done with this one. Are you ready to write a prescription for our field on that?
Well, I think you're right about the vaccine of being the mask wearing, social distancing, hand washing, cleaning the environment, avoiding large groups indoors, and the thing is, it's important for us to realize that in terms of that vaccine uptake, we're much more like New York than we are New Zealand or Taiwan. We're not a terribly uniform society, and we don't have the enforcement mechanisms because of our concerns about civil liberties and things that you might find in China and some other places, where simply, you will wear a mask. If you don't wear a mask, but we also don't have the commitment to isolate people who are homeless. We do that a little bit. We don't have the commitment to divert resources to deal with one of the largest tragedies I've seen that almost no one talks about, and that's the nursing home situation. From the very beginning, 40% of the people dying are coming from senior living or nursing home facilities. 40%, that's 80,000 deaths. Or maybe it's only 70,000 deaths. Maybe I'm exaggerating. Maybe it's more than 80,000 deaths. But I mean, what do we need to know to take these underfunded, hopeless places and do the things that obviously need to be done, which is constantly repeat testing and isolation, stopping staff from coming in, isolating people? And the answer really is we don't have the resources to do it. The nursing homes can't do it themselves. We don't prioritize them. They're just 80-year-olds anyway. I mean, we're letting that discriminated population die, essentially. The population you've done so much work with, Linda, it's unconscionable that 80,000 deaths can occur among people with nursing homes, and they can be dismissed as elderly people with chronic conditions who shouldn't be dying. I mean, they're sitting in their nursing home. They're not out there doing partying, going to bars and, all that kind of stuff. They're dying in their nursing home because it's being stuck in there because we don't test the people coming in and we don't get it done. And it's largely because there are too many of them for us to grapple with. I tell you, in China, they'd do it. They'd grapple with it. They'd figure out a way to prioritize it to stop the deaths. So we're not even stopping the deaths the way we should. The other thing about the vaccine that you're mentioning is that, our country is not only politically divided, but we're getting prevention fatigue already. And it's difficult to keep this kind of intensity up. And we're very skeptical of government. I mean, if we had a vaccine that was one shot that was 80% effective, we'd have trouble delivering it to our population that's very skeptical. And that would be, the reason infectious disease, we like vaccines so much, is you don't have to deal with people as much as you do with the rest of the stuff. You don't have to get various groups of people to wear masks and socially distance. You can just stick a shot in their arm and you can be done with it. But then we find out that some people don't want to get a shot in their arm, and we got to go back and dealing with people again. But I think we could, the fact that you can do this in New York and hopefully you can keep it up in New York is very promising to the rest of the country.
Yeah. It's interesting. If you look at the point at which the US started to disinvest in its public health system, it was actually around the time of the development of vaccines for the very first time, and antibiotics in the late 50s and 60s. And at that time, it's plausible to think that our excitement that we could get one shot and not worry about prevention perhaps took hold in our imagination. Now we're at a very different point in history for all the reasons that you just said, Jim, about disaffection with governmentally led vaccination and et cetera. But also, I think when we think about vulnerable populations, we actually probably have, well, I know we have populations with a much higher proportion of people who are vulnerable due to long histories of chronic disease, plus some of the physiologic vulnerabilities of getting older. We never had populations who were this long-lived in 1960 or 1980 even. And we never had populations who were living with so much chronic disease for so long, which is a feat of medical care, but a demonstration of the lack of investment in prevention as well. So in a lot of ways, we have very different conditions in terms of protecting people than perhaps we designed for 40 years ago. And need very much to think from a public health system point of view, how we design to protect people in populations with a large proportion of chronic illness and vulnerabilities, who we never really built systems to protect before.
Well, you know, the other side effect of the COVID epidemic is the concurrent epidemics of morbidity and mortality due to conditions which have been created or neglected other than COVID.
Right.
So we're already seeing our hopeful change of deaths due to diseases of despair, drug overdose, suicide, and to some extent homicide being reversed. So we're seeing again an increase in overdose deaths, an increase in suicides, an increase in homicides. And we're going to, we're just starting to document the increase in deaths from other chronic diseases. I know at Emory, for example, the cancer patients are coming in later than they used to, either because of lack of health insurance or because of fear of going to the hospital or doctor, because of COVID or a variety of reasons. So we're going to see, I think, some increase in cancer mortality rates from people coming in later. We're going to see, we've already seen some increases in cardiovascular mortality and certainly homicide, suicide, and a huge increase in the mental health, mental illness burden in the country, all of which is related to the ongoing COVID pandemic and our response to it. And you could say distraction from it. But that's extremely important. And you don't know how it's going to change our health system in the future in dealing with these things. I mean, telehealth is certainly here to stay, but it may not be the best for a lot of things. It's being promoted for mental health. Well, maybe that's good, but maybe it isn't. So we have to see whether we've had reverses in morbidity and mortality. Already before COVID, we were seeing increased mortality rates, particularly in white men, but also in other populations due to chronic diseases, and a decrease in our life expectancy. Now, this is occurring before COVID due to a variety of factors in our society, unrelated in part to the conditions themselves. And I think this is going to accelerate that and reduce our life expectancy even more.
Yeah, so I would agree. And a lot of the rise of other pandemics, if you will, over the last 30 years, like overweight and obesity population-wise, is clearly a factor that puts people at risk, and clearly one of many factors that have caused the US health status to fall over the last few decades to the bottom of peer nations. So going back to Jerry's opening point, taking all of this as a package is very important to understand, because many of the clues to protecting in COVID have to do with going to understand who's at risk for because of pre-existing health burdens. And many of the approaches we need to take, even to prevent mortality, have to be done in recognition of that. So the other factor that I have been thinking a lot about in all of this is because of the US population's distrust of government, it erodes our recognition of the importance of governmentally led public health system, which is in a lot of ways to me, the quintessential definition of what a public good is. A public good being something that we need. In fact, it has to be led to deliver to everybody, to raise the floor and the ceiling of health for everyone through all the different mechanisms, and everyone gains, but no, there's not a profit to be made for anyone. And so no one sector, no one corporation really sees value in investing in public health and the prevention and health promotion that it's responsible for, but everybody benefits when it's there. And when it's delivered in a way that everybody can experience benefit, then you get this population-wide protection that you were talking about, Jim. So I deeply hope that the other learning from this pandemic is to appreciate the critical nature of this public good, that it delivers, but we need more of it. And we need it well designed for the conditions that we are living now and that we know are going to unfold in the coming years. So Jerry, I see you leaning in. Should we turn to you to get questions from the audience?
Let me see, am I unmuted?
Yes, you are.
Well, those are two spectacular presentations, an incredible conversation, and I think it's been a real privilege to hear them. Let me ask this. We're effectively at the moment without a CDC. That may be a little strong, but the CDC's credibility has now been eroded to a substantial degree. And I wonder if you would each speak a little bit about the likelihood or the trajectory that you see for that drop in CDC credibility and the paradoxical increase in the sort of bad visibility it's getting, and how long you think it's going to take and what it will take to bring the CDC back to the kind of persuasive and, in fact, functional power that it traditionally has had.
Well, Jerry, I'm very concerned about that. I think, and it's worse than I've ever seen it. As I mentioned before, we've been neglected, and a lot of us have always felt underfunded when I was there, but we haven't been interfered with so much. Now, the interference is not just with the CDC; it's also with the FDA and science in general. But Tony Fauci really sort of speaks for himself. He has a lot of employees, and they're quietly helping to develop vaccines, but they're not often called on to be public media people. The CDC is developing information all the time. And on the one hand, if you read the MMWR, every week there's about 2 to 4 articles on COVID. So they're continuing to do the investigations. I caught up last night because I thought you might ask me questions. And there were, in the last month, there have been 16 articles in the MMWR about COVID. When I was at CDC, we had 350 articles in the MMWR on AIDS. The difference was we were always there to talk to the press about an article every single time, interpreting it. CDC's been totally shut out. I mean, none of these articles a lot of them are very important when you read them. An epidemic in a childhood camp. I mean, 70% of the people were infected in 2 weeks. I mean, that has enormous implications. Now, the thing is, it came out just before school started. So if you got somebody from CDC talking about it, the press would say, what implication does that have for the opening of schools? Well, the administration didn't want anybody to ask that question, so they didn't put anybody available to the press. So the CDC cannot talk to the press. They're forbidden to talk to the press. And even worse is this Caputo Anderson stuff about changing the guidelines and minimizing the leadership. The president has personally criticized and minimized Dr. Redfield, Dr. Fauci, Dr. Hahn, has said bad things about them as if they're evil people. I mean, that's not a civil thing to do. And it's very, very demoralizing. And so, that has to stop. So if you assume if there's a different administration or a different attitude in the administration, I think the CDC can come back. They did some things. They did some things that were wrong, but they got criticized mostly for doing things that were right. So initially, the CDC and Tony Fauci and everyone else tended to assume that the epidemic wasn't going to be as bad as it is. We can do better than, we can do better than China. We can do better than Italy. It's not going to be that bad here. And the CDC was initially part of that. But Dr. Messonnier and Dr. Schuchat came out and said, hey, this is going to be terrible. And they were, Messonnier was essentially fired for saying that it was going to be terrible. And she's, her brother is Rod Rosenstein. Well, and he was minimized and moved away. Messonnier is not a, card-carrying Democrat doing anything wrong. She basically said this is going to be a bad epidemic and caught the White House by surprise. Well, you don't want to catch the White House by surprise, but in retrospect, she was right. I mean, we should have let you know I was going to say this, but I mean, basically I was right. In the AIDS epidemic, I used to be called down to the HHS because when I give a talk, I'd say, this is going to be much, much worse. It's going to be much, much worse. It's going to be much, much worse. I get called down there and say, why are you scaring people? And my comment always was, I'm probably underestimating it. And in truth, I always was underestimating it. It was actually worse than I said it was going to be. And Nancy Messonnier was underestimating it. And they don't have to set policy at CDC, but they have to be seen as getting out the truth and telling you why they think it's the truth instead of being marginalized. So it's very demoralizing for scientists. A lot of people that work at CDC could work elsewhere and make more money, or they wouldn't be working in the areas where there are essentially no other experts in the world. I mean, there's no place with more respiratory disease epidemiologists and scientists than CDC. What if they didn't have any? What if they all left? I mean, it's just terrible. So I think we need to defend them vigorously. And I understand the New York Times had a long article today, which partly did that. I know Science is going to be coming out with an article. I think they finally fired Caputo, or he went on sick leave, and they got rid of this guy Anderson. Scott Atlas needs to go next. I mean, we just can't have people with no credibility at the top of our government talking about things they know nothing about. And we need to give the voice to the people who do.
So I'll just also add that I think it's really critical, Jerry, that schools of public health, just as we're doing, speak for the importance of governmental public health as a public good to protect the health of Americans. I mean, CDC experts that Dr. Kern just described take seriously bringing more expertise than you can find anyplace else to preventing epidemics and the spread of disease, as well as expertise for the other health challenges that Americans face. But they are not in a position often, because of their responsibilities as governmental employees, to explain that to the public. And it's critically important that we as citizens, we as scientists, we as public health professionals speak to the importance of what they do and how much more we need of them. And in addition to needing the science and needing them to provide interpretation and unified leadership to actually control this epidemic and pandemic, we need to look at what functions of the CDC have actually been stripped away in this pandemic. So the reassignment of the core CDC function of monitoring health status has been reassigned outside of the agency for reasons that I do not see evidence will actually aid in understanding what's really going on. There are other things that have led to not just demoralization, but inability to monitor and track and advise the public. So there are so many functions of the US public health system where I think our infectious disease control is the tip of the spear that calls us to attention when there's a pandemic. But we very much need, as a public, to be speaking to how important it is, and from a school public health point of view, to be doing the kinds of things that Jim is doing at Emory and that we are talking about in terms of using this opportunity to think about how to build the kind of public good of a public health system for the 21st century that actually will protect and promote the health of Americans.
We have a question here from, it says, an anonymous attendee. How can universities work together to help influence policy and make it change? And I would take that down a notch and ask, what about the schools of public health presenting a unified voice and a coherent message for the public, and doing so recurrently and at scale? Is that possible?
So the core functions of public health are assessment, policy, development, and assurance. And good policy is based upon the facts and good science. And you can put the science into what we know about natural history of infection, or what we know about prevention of cardiovascular disease, or whatever. But the main thing is you have to have ways of transparently keeping track of it. And if you want to if you want to call attention to a public health problem, you need to have the facts and the data. And that's why, we're upset about CDC not out there presenting the data and presenting the data every day, because that's the responsibility of government to do that assessment. If you want to minimize a problem, you get rid of the surveillance system. You don't know anything about it. So when you see a new problem come up, the public health people, the first thing they always do is set up a surveillance system, set up tracking of this. And that's what leads to change. The vast expanse of opioid overdoses was kept track of. And by tracking that, we finally were make a change in the dialogue about drug overdose and about where opioid use policy. But it came from the data, it came from tracking the data. And that data is how policy should be set. Now, there are going to be other factors that deal with policy. So CDC shouldn't be setting all the COVID policies, but they should make sure that the adequate data and its interpretation are there to bear. If people want to open schools anyway, then they should do it with the idea that they can, what they can do to prevent this from happening, and they ought to be aware of what the risks are and not surprised by them. And that means we start with good data. The second part of policy development is advocacy. And the advocacy comes from scientists and other people and students speaking out and being involved. So to give a complicated issue, you have issues. Another horrible problem that's going on is police violence. And one of my faculty and one of your faculty, Mindy Fuller-Love and Hannah Cooper, just wrote a book on this, on police violence in the United States. And it's very timely because of what we've been seeing. And so the protests against racism in the United States and police violence are coming at the same time as COVID. And I think it's no really surprise that concerns about inequity and social determinants of health and racism are coming along at the same time as COVID. And these are parallel processes. And to some extent, protests against racism are actually protests for public health, because racism and social inequality is also a public health problem. So how do you reconcile that with COVID? What I advise our students is to protest if you wish, do it outdoors, socially distance, wear masks, and take another dozen masks with you so you can have other people wear masks, and wear your public health sweatshirt if you have one. In other words, these are both goods, but they should be done safely, and they should carry both messages. because you can't turn back the passion of people who are concerned about fighting for civil rights, getting in good trouble, as John Lewis used to say here.
So I would also totally support what Jim just said and just expand to another dimension of your question, Jerry, about how schools of public health could and should work together. Certainly, Jim and I joining together today is one demonstration of that, and there is a tremendous amount more that we are doing and will do.
All right. We have a zinger question here from Brian Lafrancois. Do you think the devolution of responsibility for addressing the COVID outbreak to the states was a mistake?
Well, I think my short answer would be yes. The longer answer is the federal government doesn't have much control over the states. The federal government has much more control over foreign policy than it does over domestic policy. It rules domestically largely through the money it gives to states for a variety of things. And so it can put strings around the money. And, you know, it does have, the FBI has some state authority. There is epidemic authority between states, but these things are relatively small relative to the problem. So it's really more of a question of coordination of states than it is control of states. And that's why leadership is so important. And again, going back to New York, you know, the apologists, the people who say New York's not a good example would say that, well, you know, it's a heterogeneous state. They're all Democrats in New York, and they all get along with each other. And I don't think that people know Mario Cuomo and de Blasio and the people in New York very well to say that they're easily coordinated just because they have a Democratic governor and Democratic mayor. Now, I think that is important, but it's much harder to have leadership than simply Democrat and Republican. But if the president, for example, were to say, I mean, this is fanciful what I'm going to say, so nobody's going to believe me. If they were to say, look at, you know, say 2 months ago, I'm going to put this campaign aside and I'm going to call on Vice President Biden not to do any campaigning outdoors. And for 2 months, we're just going to work together on COVID. We're going to shut down the country where we need to. We're going to make sure there's universal mask wearing. We're going to have universal social distancing. We're going to do all we can to get testing out there. And I don't want this to be a partisan issue anywhere. I'm going to encourage all of our governors, Democrats and Republicans, all of our mayors, Democrats and Republicans, to all work together to do the consistent things. And I want this not to be partisan at all. That would go a long way. Now, you know, there may be some states that say, I don't like the president doing this. I think he's getting in my way. But I know in Georgia, Texas, Florida, with Republican governors, they just feel like initially they could do anything they felt like because the president told them they could do anything they felt like. And now they're paying the price for it. And I think that we could have been encouraged to have a lot more uniformity. There may not be a national mask mandate, but there should be a national mask expectation. Every state and every city should have a mandate, and they should be encouraged to have a mandate, even if there couldn't be a national mask mandate. But that takes real leadership and consistency that we haven't seen.
Okay. We have another question here, which is an interesting one. Also from an anonymous person. How do you think politics and finances will affect the distribution of a vaccine in the early days when supplies are limited?
I would say I'll answer this domestically and then globally. One thing I would credit the administration for is the bets they have on vaccines. So there's a lot of things that, you know, I mean, it's amazing that there are 175 vaccines that are being developed. and a number of them are in late stage study. Now, to think that we actually have phase 3 trials for vaccines for a virus which was discovered in January is absolutely amazing. Now, we know some of them are going to work and some of them may not work. Maybe none of them will work. Maybe they'll all work. And if they're shown to be efficacious, and then the next step would be to make sure there's enough of them made to distribute. Now, what the administration has done is they've gotten some bets out there by pre-buying hundreds of millions of doses of at least 2 of the vaccines. That's this Project Warp Speed. Now, you know, the good part of that is that there are going to be vaccines available in quantity for the US public, at least for the vaccines that we purchased ahead of time, and they will be produced quickly. So that's the good news. You know, you could say, well, you know, why did you do those vaccines and not others? And that has something we have to watch out for to make sure that the vaccines that are recommended and available to the US public are the best ones. But the nice thing is there's going to be a lot of them available as soon as they're shown to be efficacious. Now, having said, and there have been priorities set up, and the National Academy of Medicine was paid by, I think, CDC and NIH to develop priorities. And the first group of priorities are essential workers, particularly healthcare workers, and those with increased risk, who are defined as those with pre-existing conditions and the elderly. That makes some sense, and it makes sense to kind of get moving on that stuff. And we have some bets that have been placed with billions of dollars of vaccines pre-purchased. When it comes to the world, you know, I mean, we can't isolate ourselves from the world, and we've yet to see how bad this could get in Africa and developing countries. We're starting to see how bad it can get in India, and we've seen what it's like in Brazil. There's no reason to believe that it can't be really, really bad in a lot of African countries and in the Caribbean and other places. But if we want a world that's safe to traverse, we're going to have to figure out a way to prevent COVID everywhere in the world. And we're talking about, you know, almost 8 billion people, 7.5 billion people. So figuring out how to do this, it's simply not going to work with a crappy vaccine. So if it's a vaccine like influenza, it's going to be very hard to get the energy and the programs up to give people a vaccine that's 50% effective that only lasts for a year. But if we get something that looks like it has lifelong or long-term immunity and long-term protection with pretty good efficacy, we've got vaccine programs set up, largely with children, but we've got ways of setting up to distribute vaccines to the developed world. But to get the funding and the energy to do that, we're going to have really good vaccines. And we're not going to know that in 2021. It's going to be much later. Now, there'll be calls for global vaccine distribution as soon as the first one's effective. And I think the AIDS epidemic and the idea of providing lifelong treatments for people got energy based upon a lot of those calls and the idea of the AIDS epidemic in Africa. But I think with vaccines, there's going to be scrutiny about the quality of the vaccine, whether or not it can be distributed without a cold chain. There's going to be a lot of issues that are going to be asked by those people who are experts in immunizations about that. And there'll be, just like there has been with polio vaccine, concerns by some countries that have Muslim populations and others about poisoning people and a variety of things. I don't know if I hope that's partly answers the question.
I think so. I think we have time probably for one more. Another zinger. How can the media be helped, coerced, or otherwise aided in providing effective, recurrent, authoritative information directed to the public?
I think in the United States, the media has been our savior. There's always going to be the risk that they're seeing, because of the partisan nature of this, that their truth telling will look like it's partisan. And I think that I don't know how to deal with that exactly. Sanjay Gupta is a good friend. You know, he's a neurosurgeon on CNN who I think has been remarkably good and knowledgeable. He has everybody's phone number on his Rolodex and calls them all the time. So he's constantly talking to people inside NIH and CDC. And I think that the bringing all of the various pundits around the country on the shows every day on TV is a good example of what can be done. The New York Times has been terrific, Washington Post, even the Wall Street Journal, Atlantic Magazine. A lot of people are getting out the facts and bringing people to bear. So I think the press has been terrific. And I think the main thing is they need access to the experts. And they're doing pretty good.
I agree. Linda, any comment?
Oh, I totally agree. And I'm very proud that at Columbia's Mailman School of Public Health, just during the pandemic, our faculty have given well over 1,000 interviews to the media in order to educate the public, in order to bring the science, bring the facts to the public, because it's not going through other vehicles, including leadership. And that's been incredibly important. And part of our mission is to deliver knowledge for the public good.
And you know, you guys at Columbia have been terrific. And I think that that's a sign of the importance of public health researchers and scientists speaking to the media. A lot of the people who have been doing the modeling and communicating on TV and other places are and blogging and publishing are public health researchers and faculty members. So that's a sign, I think, of the importance of public health research, which gets you back to your mission, Jerry.
Well, it's hard to thank you two enough for a spectacular and powerful and very informative session. And I wish I could do something more palpable than thank you in a virtual sense. And thank you to our attendees and our questioners and so on for being here. And with that, I think we are adjourned. Thank you again.
Thank you. Take care, everybody.